Hi, everyone. I'm Linda Tintawi, CEO of the Lustgarten Foundation, and I'm very pleased to welcome you to Unlocking Early Detection from Precancerous Clues to AI-Driven Discovery. We have a large and enthusiastic audience joining us for the number one area of research most often asked about by our patients and families. And this is not surprising given the exciting and groundbreaking work being led by today's speakers. But before I hand the baton to Andy Rakeman and our guests, I'd like to provide some background. Lustgarten has developed a collaborative, goal-oriented program focused on uncovering the events that lead to pancreatic cancer before it has formed. Our vision is to create new tools to stage, detect, and intercept pancreatic cancer. Our three areas of focus are understanding the origins of pancreatic cancer, spurring innovation by developing novel approaches to early detection and interception, and developing AI tools for risk assessment and detection. Advances led by Lustgarten are changing what is possible. Early detection through surveillance, the CAPS program screens for pancreatic tumors in people with a family history. The origins of pancreatic cancer are coming into focus, and new approaches pioneered by Dr. Laura Wood, who you will meet in a moment, are providing a view into the earliest stages of this disease. Finally, AI can illuminate the invisible by demonstrating the ability to identify pancreatic tumors missed by radiologists. You will learn more about this from our second guest, Dr. Elliot Fishman. None of this research would be possible without our donors, so I'd like to thank the Paul M. Angel Foundation for their transformative gift, Glenn W. Bailey Foundation, the McAdam Family Foundation, Revlis Foundation, Sinelli Family Foundation exclusively supporting Dr. Laura Wood, Herbert Simon Family Foundation, A Gift in Memory of Diana Salmonson, and finally, Lucy Shostak. Thank you to all of our amazing donors. So we are anticipating many questions from our audience today, so I encourage you to use the Q&A below, and we'll do our best to answer them throughout our time together. But please remember that our guests cannot answer questions about a specific case. And now it's my pleasure to introduce Dr. Andy Rakeman, Lustgarten's Vice President of Research. Andy, today's program is exciting for many reasons, one of which is that our turbocharged efforts in this field reinforces how Lustgarten-funded science has driven every major advancement in pancreatic cancer research since our inception. I know I've said this before, but we are truly at an inflection point for finding pancreatic cancer earlier when it is still curable.
Yeah, Linda, I agree. It's a really exciting call and a really exciting time for pancreatic cancer research. And I'd say it is an obsession that we have with doing better for our patients. And a lot of that is finding pancreatic cancer earlier. And I think, the response we've had from our community for this event really shows that the need for better mechanisms to detect pancreas cancer is something that everybody who's experienced the disease understands. That's something really fundamental that we have to be able
Absolutely.
to do better. And it's also been a bit frustrating that we haven't had the kinds of solutions available to patients yet to achieve those kinds of goals. So what I hope people get out of this discussion today is not just an understanding of why we need to do better or what we want to achieve, but really understand why this has been such a challenge in pancreas cancer. What's different about this disease? Why is it tough to find early, and why is it so important to find early? And more so than that, really understand what's different about this moment right now that's giving us some more hope that we can do something different, that there are changes in the kinds of technologies and techniques that are available. There's new insights that we're getting into about the disease that are really creating opportunities for us to do some real focused, collaborative, goal-driven research that's going to get us closer to achieving that goal of having methods to find this cancer earlier. So
Those
very,
are great points, Andy. We look forward to this conversation.
yeah. And more so than that, we also have some wonderful guests to talk to us. One of the things that I've learned through my time at Lustgarten and my career as a scientist is if you really want to understand a disease, you're best to talk to the folks who are looking at the disease, right? So we're delighted to be joined today by a pathologist and a radiologist, two people who use very different kinds of tools, but really spend their day jobs looking for and looking at pancreas cancer and have a unique perspective or a really, intimate perspective on what this disease is. So with that, I'm, really excited to introduce our guests today. And I'll be joined in this conversation by Dr. Laura Wood, who's an expert pancreatic cancer pathologist and associate professor of pathology and oncology and medicine, and the director of the GI and liver pathology and deputy director of the Saul Goldman Pancreas Cancer Research Center, co-leader of the Cancer Invasion and Metastasis Program at Sidney Kimmel Comprehensive Cancer Center at Johns Hopkins School of Medicine, and as you will hear from her, a brilliant researcher and clinical pathologist. And we'll also be joined by Dr. Elliot Fishman, who is a real pioneer in using artificial intelligence to revolutionize cancer imaging. And he's professor of radiology, surgery, oncology, and urology at Johns Hopkins Hospital. Also a brilliant scientist. I'm sure you'll hear from his stories, his quite adventurous career that's brought him to this point of using computer and AI methods to really be able to better detect and treat pancreas cancer earlier. So Dr. Wood, Dr. Fishman, thank you so much for being here and joining us. And I know the community is really appreciative of you taking the time to teach us a little bit more about pancreas cancer early detection and what's happening today.
Thank you so much for having us.
Yeah, great. So I think, perhaps before we get into what's exciting about today's research, I think it'd be good for our community to get to know the two of you a little bit. So I'll give you each, the opportunity to introduce yourselves, talk a little bit about, your work and how you got here, but, maybe really give some insights into what inspired you to study pancreas cancer and to enter into this field. So maybe we'll start with you, Dr. Wood.
Yeah, so I have done an MD and a PhD degree, which means I have both clinical training and formal research training. And my research training was in a field called cancer genomics, which means looking at the defects in the genetic material and in cancer cells that may cause them to transform into cancer. So that was kind of where I came into the pancreatic cancer field with that background. But I was inspired, by both the multidisciplinary community at Hopkins and the pancreatic cancer field more broadly, both by how devastating the disease is and how much room there is for improvement, but also how many unanswered questions there are in the initiation and progression of pancreatic cancer, and thinking about how we can apply, molecular techniques and understanding it at the tissue level to hopefully make a difference for our understanding of early tumor genesis and then apply those technologies to patients.
I know that's great. I think that's something we hear often from the scientists who choose to take a career in pancreas cancer, that the challenge is what's inspiring and it's what really motivates folks to come into the field. Dr. Fishman, do you want to take a moment to say hi and give some background to our audience?
It's a pleasure to be here and an honor to be here. Yeah, my story is a little different. I started at Hopkins doing CT scanning. Everyone knows what CT is. In those days, it took a minute to get a slice, not a second to scan the whole patient. Very early on, believe it or not, in the mid 80s, there was a company you may have heard of called Lucasfilms that was looking at ways of using computers to look at things, including images. And I flew out to California, San Rafael to be exact, and that company became Pixar. And the goal and what they showed me was that, hey, you could look at the images, but you only see a small amount that's really there. So we spent many years working with Pixar doing 3D medical imaging. We went from there to Next and Silicon Graphics and eventually to NVIDIA and Apple. And our goal was to try to figure out how can we find things better. We know that the scanners got better, the resolution, everything is better. But if you look back, there's an article published 2 days ago that showed the miss rate today for radiology is the same as it was 60 years ago. That's not exactly what I would call progress. So, and at Hopkins, I had the pleasure to work with Dr. Cameron, who was the head of surgery at Hopkins way back when. And Dr. Cameron's interest was in pancreatic cancer and Whipple's procedure, which Dr. Cameron, I think, had the most Whipples. I think he's done 2,500 in his career. And he basically said, okay, you better learn how to read those scans and do things better. And like Laura said, we all learned a lot, but the frustration of not being able to help the patients because we were picking up cancer, but it was too late. So the question was, could we do better? And then, with the computers, you can't read a newspaper, or not that anyone reads a newspaper anymore, but if you did, or on the radio, every day AI is making these major leaps. And I think you'll hear in this discussion that AI is going to have the biggest impact on medicine of anything we've ever done. And I think in pancreatic cancer, it's really a game changer. So I think that's what I'm very excited about, and appreciate the Lustgarten Foundation supporting our work in that area.
Yeah. And we're excited too, Dr. Fishman, and really excited to see this going forward. And one of the things that working with you for a while now and talking with you, I'm always impressed with our limitations as humans in terms of how much more there is for us to see and experience that we miss, but the computers can find. But maybe before we dive into what's new and what's for the future, maybe we'll level set a little bit for our audience here today and ask the two of you who both work in the lab and in the clinic to put on your clinician's hats and maybe talk a little bit about, well, how is pancreas cancer diagnosed today, particularly as, radiologists and pathologists, what's your role in that process going forward? Maybe Dr. Fishman, since you started talking about what we missed from the scans, maybe just walk the audience through a little bit. How do you come into the picture, and how are you detecting tumors today?
Sure. I think if you look at it, really pancreatic cancer is detected one of two ways. One is a patient is symptomatic. They may have some abdominal pain that's not explained. They may have some weight loss and other symptoms that brings them to their doctor, who then gets a CT scan to try to figure out what's going on. Or they may have some blood tests which show some issues. The other way we detect pancreatic cancer is patients have a scan. Maybe they have hematuria, blood in the urine, so they're getting a scan of the kidney. But when you scan the kidney, you also see the pancreas. Maybe someone had, back pain, and you're getting a scan of the spine. So it's really two different ways to go about it. But the majority of patients, the challenge is that people present late. So when you have symptoms, the chance of the lesion being pancreatic cancer being very early stage, it's what's worrisome. And so one of the things, well, Andy will speak about and Laura will speak about is how do you do that earlier? Once patients have symptoms, the chance of being stage 1 or stage 2 is low. So I think, our goal is knowing how things are done now, but how can we do them fast forward?
Yeah,
And
no,
I
go
was
ahead,
just
Dr.
going to say, I think the role of the pathologist kind of takes over after something is identified on a CT scan, as Dr. Fishman mentioned, where that tissue is sampled usually by a gastroenterologist or interventional radiologist. There's an abnormality seen on imaging, but the imaging can be suggestive, but often not definitive. And so that tissue gets sampled with a needle, and then that tissue is made into a slide, and that's where the pathologist looks at it under the microscope and can really give a clear idea of what's going on. Is it, pancreatic cancer? Is it, something benign? And so we play a key role in really the diagnosis of what the abnormality is, the specific tumor type. Also, if a patient does undergo surgery, the pathologist plays a really important role in examining that surgical specimen and doing grading and staging of the tumor to give prognostic information, which can influence therapy. I think the other thing that's becoming much more important in pathology is doing molecular analyses of the tumors or of other biosamples. And that's another role that pathologists play, is once the tissue is obtained, to decide what the relevant tests are that may influence therapy or may influence risk, and then having those tests done.
Yeah. Yeah, that's excellent. So if I can summarize a little bit, maybe, and correct me if I'm oversimplifying this, it sounds like maybe we're starting to get at what are some of the challenges here. And it sounds like at each stage in the process, from having a symptom and showing up to your doctor and getting a scan and getting it looked at molecularly, our tools are just a little bit blunt, right? The symptoms that have people show up to the doctor appear late, and they're sort of vague, and they're not necessarily specific to pancreas cancer. There are some blood tests that can be suggestive, but none of them are really specific. As you mentioned, Laura, even if you have a good image and it looks like there might be a mass there, that's often not enough to give a diagnosis by itself, that we need to go and do an invasive procedure and a biopsy and get this in. So I think it starts to map out that, there's some challenges with the disease, that it's, small and the symptoms are vague. And there's room for improvement in our tools all along that process, right? And that detection itself is not a one-step event, right? It is a process that involves medical oncologists or even GI doctors and radiologists and pathologists and all along the path. And I hope, we'll get at it, how do we make sure that those are all working together? Um, I will say there's one area where, and Linda alluded to this in her introductions, where we have had some success of showing that if you can bring all these groups together, we can find tumors earlier and get people into more curative therapies and have better outcomes. And that's in the folks who are at higher risk who get enrolled in surveillance programs like the CAPS program that's now national but run out of Hopkins. So maybe and maybe I'll ask you, Dr. Wood, to start. Can you describe a little bit, who is it that we put into these surveillance programs, and how do these work overall to find tumors in people who we consider at higher risk for developing pancreas cancer?
Yeah, it's a really important issue. I think that most of our high-risk patients right now are based on either family history or having a germline mutation, meaning a defect in your DNA that's inherited through your family, rather than a defect in your DNA that happens just in the tumor. And so if you have a strong family history of pancreatic cancer, or you know that you have one of these mutations that runs in your family, that puts you at higher risk. And that's currently the group of people that are targeted for surveillance and CAPS and in other programs. And I think that it emphasizes the fact that pancreatic cancer, though a very important disease, is not super common. And so in general, screening the entire population right now is not really feasible, because even if you had an almost perfect test, you would still have too many false positives. And so one of, I think, the paradigms of surveillance is really risk stratification, of defining who these high-risk populations are. And right now we do that based on, family history and other, genetic conditions. But we also miss a lot of people that way, because most patients who have pancreatic cancer don't have a family history. And so I think while it's important to consider that high-risk group, we also need to be thinking of what are new ways to risk stratify people, to put more people into that higher risk bin who really do need surveillance, but we're not getting right now.
Yeah, that's it. That's another excellent point that I hope we'll come back to, this expanding our definition of who's at risk. Whereas, as you alluded to, Dr. Wood, it's, I think, 90% or so of cases today are sporadic, meaning that there is no previous family history or reason to suspect. And those are folks that we would have missed now. And there must be something else that would put them in a risk category, but we just haven't been able to define that yet. And then for you, Dr. Fishman, I know that surveillance, it's not just identifying who's at risk, but then it's putting these people in regular imaging along the lines to try to track, to make sure that it's going on. So maybe if you could give a little bit of color for the folks about, what's kind of state of the art for imaging for surveillance now, and kind of where those limitations are.
Right. As Laura said, it's a small group of patients. It's measured in the 25,000, let's say, numbers. The challenge is, if you really want to survey and watch carefully high-risk patients, you're basically doing it now at 6-month intervals, typically using MR and endoscopic ultrasound. Endoscopic ultrasound allows you to do, tissue sampling and fluid sampling, but it's more invasive, has higher risk. MR is an easy study to do, but you can think about it from the patient's perspective. Imagine getting a study every 6 months. Just the sheer fear of getting that exam and what the results are is really high. And then if you're being practical across the population, you can think about what the costs are. As Laura mentioned, if you want to be, the 61,000 patients in the US a year get pancreatic cancer. If you want to find the 58,000, you got to figure out a better way. We need, whether it's things like, and we'll speak about a lot of work going on now with liquid biopsies. Is there something, a lot of work Laura's doing? There's companies like Grail and Exact Science that are looking at 50 cancers. That's something that was only a dream before, and that's going to get better. You're looking also, we talk about the fact that in the US, 40 million patients get a CT scan a year for many reasons. Can we look at those scans through a magnifying glass and find early cancer?
Mhm.
When we have conference every Tuesday, we have new patient pancreatic cancer conference, and we do anywhere between 5 and 10 patients a week. Invariably, every week or at best every other week, when I look at not the scan from today that they got at Hopkins, but the scan they got 2 months ago, 4 months ago, a year ago, 2 years ago, the tumor was there. And when they first had the tumor, they would be resectable and probably cured. Today, they're going to have to go chemotherapy, and we're going to hope for a good outcome. But, that's one of the things that drives us in the push forward is the frustration of knowing that what if it was there, but we didn't see it? How do we make that not happen?
I also think I totally agree with Elliot that finding the early cancers that are visible is really, really important. But I'd also like to push that we should be going earlier. And if we can identify features on the imaging, not so much a cancer, but texture features that mean somebody's at higher risk, right? Our finer and more nuanced imaging feature is going to be a way to risk stratify patients, right? Not saying this person needs surgery, but this person is at higher risk and, needs either interception approaches or needs increased surveillance. I think that would also be really useful.
Right. Now, I'm a radiologist, so of course, radiology is great, but the way I kind of look at it when I want to be really critical, all of you have seen the Hubble telescope and those incredible pictures. Okay, which means when I went outside last night and looked at the sky, that Hubble stuff is all in the sky, but all I saw was a moon and a few little dots, which are stars. Okay, the information is there. We just can't see it. That's what's really exciting, the ability to be able to, as Laura mentioned, we've learned a lot. There's something we do called radiomics, which is a way of looking with mathematics at the scans. And it's been shown that with radiomics, even if the radiologist looks and knows there's a tumor and still doesn't see it, the mathematical formulas can predict who has a tumor. So imagine now you're picking it up before we could see it. Even if we knew it was there, we don't see it. It's kind of the Hubble approach to doing things. But that's going to be really exciting because now you're talking, there's been several articles that show it 2 or 3 years earlier. And we're doing a lot of work looking at that's one of the most exciting, possibilities.
Leah, do you think though you're catching the cancers earlier, or do you think the radiomics is picking up kind of pre-malignant features that put somebody at high risk for developing cancer, or is it too early to know?
Yeah, it's always hard to pray because if you look back, I mean, there was one article from Mayo Clinic where they had looked at a couple hundred cases. Even in retrospect, they saw none of those atrophy signs or focal fat. They just had the radiologists just read them as cold turkey normal.
Hmm.
But now are we seeing early changes? But we're doing a lot of work here, and you guys are involved with looking at that, and the results seem very, very positive. And again, it's just simply the fact that a radiologist or anyone looking at a scan is always going to have limitations. Radiomics is AI. It's the computer looking at it. And I think that's how we need to really think about things is radiologists, humans are very good at doing things, but if you want to step it up to the next level, you're going to have to change how we do things.
And this has been a really illuminating conversation. And I think we started from like, well, what are the challenges out there? And it's great to talk to you because you so quickly moved to where are the opportunities to do things differently and do things better. And a few points I want to make sure we dig a little bit deeper on is one, what you were just talking about, Dr. Wood, of, let's better understand the origins of pancreas cancer, what precancers are. And can we detect those rather than detecting the tumor even if we're honest, when we do our best and have surgery, the outcomes still aren't where we want to be, right? And then what you were talking about, Dr. Fishman, of we already do a lot in terms of imaging people, and there's a lot of information that we're just, putting in the bin or not using right now. So maybe that's a little bit of a jumping off point for you to talk a bit more specifically about what it is that you're doing right now in what you call the Felix project, in terms of trying to understand, what are those other features we could be looking for, and maybe give some color on, how you would see that getting applied in the sort of current environment of medical scan and medical imaging today.
So, I mean, one simple thing, one number that we always think about, a number of articles have shown, and this is not from us, that if a tumor is 2 centimeters, so let's say an inch, under an inch, it's missed 40% of the time, even though in retrospect you can see it. So 40% of the time you're missing tumors that are resectable, and the cure rate is not 100%, but it's 60 to 70%, which would be important. Now, we've been doing work, and one of the nice things because of Lustgarten is we also have the privilege of working with Microsoft AI for Good. So
Mhm.
we're working with some of the top scientists in the world who are focused only on doing good for humanity. And there's an article we're finishing up where we've developed an algorithm now for 2 centimeter or less lesions. The accuracy is a bit over 93%. So the computer can pick up the lesions that are going to be missed. So that becomes very, very important. The whole idea about AI in medicine or AI in radiology is recognizing, when a radiologist looks at a scan, they're looking at the liver, the spleen, the kidneys, the lungs, the bowel, and the pancreas. But you're
Mhm.
looking at everything in a couple of minutes. The amount of time spent on the pancreas is measured in seconds, not in minutes or hours. The question is if the computer, a combination of AI looking for smaller lesions, looking for changes in the texture, as Laura mentioned, not only seeing a mass, but saying, okay, there's a shape change, there's a texture change. There's something we need to worry about here. And then you have things like radiomics, which we put on top of that and say, hey, this has a pattern. What radiomics does, the way we run several articles about this, but the simplest way to think about it is the computer creates a fingerprint, and the fingerprint of cancer is different than the fingerprint of normal. So what radiomics is doing is being able to say, hey, this is abnormal. What we're doing now, stepping further and out in the lab, is we're now trying to slice up the pancreas, not just say there's radiomics is saying there's a tumor, but saying precisely where the tumor is. And then what Laura mentioned about, is it really a mass or is it textural changes? Is it some precursor you're finding? I think that's what's important. So it's this idea of how we need to do things. If you look at AI, when you start looking at things like ChatGPT and large language models, the ability to combine information, I think that's really, when we look at AI in general and we look at what we do, radiologists, pathologists look at the charts, we look at history, we look at lab values, but there's so much information. You have 30 years of information in a chart, you can't read it. So now with things like LLM, the computers can produce the information you need. And the question is, if we have all that information and we have the new information from pathology and lab tests and the new imaging information, what if? What if we put all that together? Can we reach that dream of early detection and saving lives? And that's what
Yeah.
keeps us going.
And I think that point of combining all of this data is
Yeah.
something we'll definitely come back to at the end. But one point I also just want to make, I know, Dr. Fishman, that I think you were getting at is you started from one of the challenges is if we wait for patients to show up with symptoms, it's already too late. But a lot of the power that you're talking about of being able to run these algorithms on CT scans that are being done for other reasons, for an injury or, fake pain, they can be done in people who haven't had symptoms yet, who haven't been aren't thinking about pancreas as a risk just yet, and can be done in kind of in the background, right? So we're not already getting past that first hurdle of waiting for a symptom that's already probably too late. And that gets back to what I want to talk to you a little about, Dr. Wood, which you already brought up. Um, one of the things that I think has been also tough with pancreas cancer is because the tumors can be so small when they're so aggressive and it can be so fast in the early stages. It means that it's been really tough for us to study and understand the precursors or the precancers or what that transition from a normal pancreas into a diseased pancreas looks like. But this is something that, I think your work has really been illuminating for this recently. So hopefully you can, share a little bit about, what's changed that's enabled you to really get some insights, and what are you learning about those precancerous stages in pancreas cancer?
Yeah, thank you. So, as Andy mentioned, one of the main focuses in my group is studying not the invasive cancer, but studying what we call the precursor lesions. So, or precancers that are, growths that occur in the pancreas. They're not yet invasive, but they're kind of the step before, or multiple steps before becoming pancreatic cancer. And there's kind of two broad types. We started studying larger pancreatic cysts, which are larger lesions that you can see on imaging but are non-invasive. And the reason we started doing those was kind of practical, in that they're large enough that you can study them in a fairly straightforward way. But only about 10% of pancreas cancers arise from these larger precancers or precursor lesions. And so we really wanted to study the smaller ones because that is where the majority of pancreatic cancers come from. But it's challenging because they're tiny. They're less than 5 millimeters, so less than half a centimeter. At least on a traditional microscope slide. And so at least with current imaging technologies, you can't see them. And so you only kind of caught them by accident if you were examining the pancreas for some other reason on a microscopic slide. But we collaborated with some investigators in engineering at Hopkins to develop this approach to do 3D reconstruction of pancreas tissue. And so we can take, a piece of pancreas that's, like this big, and we can actually build a detailed 3-dimensional map of all of the cell types in it. And what we found when we did that with even normal pancreas was it was just full of these precancers. And when we extrapolated this to a whole pancreas, it means that, an adult person has probably hundreds of these precancers. And they share some molecular features with invasive cancer, including key mutations, but we all have a ton of them. And pancreatic cancer is pretty uncommon, so the risk of progression is really low. And I think that has been really illuminating, both in understanding, how common that first step toward pancreatic cancer is. And it really highlights that we need to understand two kind of parallel or maybe opposing concepts. One is we all have these common precancers, but it's uncommon for them to progress. So what are the alterations that cause progression? Because that's really what we want to be looking for as far as biomarkers. And then also what constrains them? What, 1 in a million of these is going to progress. What prevents them from progressing? And if we could understand that, we might be able to leverage those approaches for cancer prevention.
That's very exciting, and I think it is, and again, something we'll talk more about, of that. How do we go from not just detection, but to what we call interception, right? Doing something earlier before it turns into a cancer. And I think we'll see a lot of the tumor types where there's been successful general population screening is where there's also a way to intervene earlier. You think about like colonoscopy. People go for
Yeah.
colonoscopy, and there's an ability to see and remove the precancers at the time, right? So if we have those tools, it raises the importance and the stakes of finding them early if we can do something about it.
I
And then
think that, oh, sorry, I was going to say, in addition to the interception, I think just one question is the amount of precancer you have another risk factor that we should be considering, right? I mean, we're multiple steps away from applying that clinically because we don't have a test yet that tells us how much there is. But knowing we all have so much, but it is variable between people, is that a risk factor we should be thinking about how to measure and associating with risk?
yeah. And maybe asking you to speculate a little bit, but I think it's fair because you brought this up before to Dr. Fishman. You see these microscopic lesions. We can't detect them on imaging. You started to suggest, are there other things changes that we might see radiographically that could be suggestive of these early lesions there? So when you look microscopically in the tissue, do you see do these lesions impact the way the organ looks or functions or acts or behaves in a way? Or do you think there will be markers beyond just the lesions themselves that are detectable?
Yeah, I really do. I think it's a really important point. And I think that, with this 3D tissue approach, one of the things we've been able to do is correlate how much of these precancers you have with how much of other cell types there are in the pancreas. And what
Mhm.
we see is that the precancers are associated with what's called fibrosis. So kind of having the normal parts of your pancreas kind of, the medical term is atrophy, but just not grow as well. And so all that to say that having a precancer somewhere affects not only the precancer. I'm sorry, I'm postponing a restart on my computer. Just 1 second. Always bad timing. Minimize. There we go. But the precancer affects not only the precancer itself, but also the function of the rest of the organ. So even if the precancer itself is too small to see, it's possible that some of those secondary changes could be visible radiographically. And in the extreme cases, it can be seen now on endoscopic ultrasound for, larger precancers that cause this atrophy and a phenotype. It can be seen. I think that as the imaging technology gets better and better, it's more likely we'll be able to see even smaller ones.
And I think to go back to something Dr. Fishman brought up earlier, I think it's not only using the Hubble telescope analogy to say, can you see these other changes that are happening in the organ? But I'm sure a lot of people who have, had a pancreas cancer diagnosis or watched a family member go through will look back and say, there was, changes in metabolism or weight loss or blood sugar control or ability to digest food well that happened a little bit earlier.
Yeah.
So, and this gets back to where you started talking before, Dr. Fishman, about bringing multiple elements together in the computer, not just the imaging. So maybe, can you comment a little bit on, are there opportunities to point the Hubble telescope, not just at the images, but also at the medical record and all the other types of data we collect on patients and what other kind of features might be pulled out there?
Right. So, I mean, a simple thing you kind of just mentioned is the fact that, and there are several studies that show patients who become diabetic in their 50s or 60s are at higher risk for pancreatic cancer, almost as if the diabetes is the signal that the patient is developing pancreatic issues. The other thing, what Laura mentioned and I mentioned about the fact that, not so much looking at masses, but looking at changes in the gland texture, changes atrophy, changes in the duct. But another thing that's been looked at and has, a great potential is to look at the muscle mass. So if I look at your paraspinal muscles, there is a range of normal from someone who can lift weights as to a regular person, but there is a certain amount of muscle mass you have. And it's been shown now, it's not specific just for pancreatic cancer, but one of the signs of patients developing malignancy is muscle wasting. And the muscle wasting is not like that all of a sudden the patient's complaining, I can't lift this or I can't walk as far. They may not even know there's any issues, but the scan shows that. So a lot of work is going on now. Again, you mentioned about getting scans for many different reasons, but having AI automatically calculate the muscle volume. And if you have multiple scans, you can look for changes in muscle volume. But even if you only have one scan, you could look at for that patient and say, this patient has muscle atrophy. We ought to look and make sure there's nothing causing that. So it's not just the pancreatic cancer causing the changes in the pancreas, but it's the changes elsewhere. As you
Yeah.
mentioned, also the thing about the data, I think one of the challenges we have in medicine, and probably every business has the same challenge, but medicine, it's really acute. We have more information now than we've ever had. Whether it's labs or radiology or charts or histories, but the amount of data we use on an individual patient diagnosis is a small percent of what's available. You can't, as I said, you can't read the patient's charts, even though it's electronic now, and it's not those paper charts we all remember so nicely. You need computers to analyze the data for you. There's a company called A Bridge where they actually use AI to be able to give the patient's report. So one of the guys involved is a cardiologist, and he would say that he would spend 90 minutes reviewing a chart before he saw a patient. Now he spends 5 minutes because the computer gives him all the information he needs for that encounter. The same thing for us. What if every time we saw a patient, the computer was able to look at all the information and perhaps tell you that, did you notice the following? Is this something that may be important to you from the radiology side, the pathology side, the clinical side, or putting them all together? I think also the fact that with these large language models, who knows what the future will bring? The fact that the computers can learn. Maybe we're not looking at the right thing. I remember Ed Catmull tells a story about when Pixar took over Disney. Um, the two of the senior people at Disney complained that they don't need Pixar. They were doing fine, which they weren't. And the guy said, we were at the goal line and they brought you in. And Ed Catmull said, this is in his book, he goes, you were at the goal line. The problem was you were looking in the wrong direction. And I think that's one of the things is maybe we're not looking in the right direction. I mean, we're doing a great job and doing the best we can, but there's a lot we don't know.
Yeah.
I do think one of the challenges, though, when we think about these large models that are going to go through or are going through patient records to try to determine risk is making sure it's a model that's not specific to the data set that you have. And, there's been some really exciting work in this space, but then when trying to apply them to different institutions or different types of populations, it doesn't always validate in the way you'd like. So I think as a field, we need to be thinking about not only how to build the models, how to train the models, and how to apply them, but just to make sure that it's broadly applicable across institutions and across patient populations.
Yeah, I absolutely agree, especially when we get into this AI and machine learning and relying on data. The answer you get is very much reliant on the data you put in, right? So making sure not only the data is good, the data is robust, the data is representative of the whole group of patients we want to treat, and that we're not building in any disparities. And I think it's to, maybe a little bit bigger picture question that I wanted to ask is, and Dr. Fishman said, AI is going to revolutionize lots of things. Medicine is probably on the top of the list. But medicine's also very traditional and tends to move slow and has processes that take patient safety very high in mind and is geared towards other kinds of approaches, right? Whether it be, traditional biomarkers or diagnostic approaches or traditional drugs. So what does it take to take some of these algorithms or approaches and put them into practice and actually, not only get them in folks' hands, but get them in use and actually change the way the physicians behave as well?
Well, I guess I'll go first. I mean, I agree 100%. Medicine is very traditional and not always receptive to change. Okay, which is a good thing perhaps because you don't want to be jumping around making bad decisions. The way I think things have changed and people are recognizing they've changed in medicine, the two most highest ranked journals are New England Journal of Medicine and JAMA, from the American Medical Association. 2 years ago, both journals, and they publish a lot of different topics. Both journals individually decided that they needed a new journal. And so there's now New England Journal of Medicine AI and there's JAMA AI because they felt the changes in the field of AI will affect medicine so at such a point that they needed its own journal. The other way to look at it, the Nobel Prize. Okay, Nobel Prize, usually it's some old guy or old woman winning a prize, very, very traditional. If you look back the last 2 years, the Nobel Prize in medicine and in chemistry, physics, were given to people who worked with AI, whether it was on computing or was algorithms. So even the Nobel Committee recognizes that AI is changing everything, and by giving those people the Nobel Prize, they kind of put their mark in the ground that this is now. We don't need to wait for 30 years to show it. I think you need proof, as Laura mentioned this also. Um, we're always afraid that, like we do AI and we do patients from Hopkins or the local area. Some of the biggest dangers are you only have one set of data. So sharing data amongst institutions, sharing information. The NCI is going to release a large data set that was from all over the country of preclinical scans, which are scans done of patients before the cancer was diagnosed. And that's for many institutions. So you'll be able to test your algorithms and make sure it works on that data. Otherwise, you're right. You're right. There's sepsis. There is a program for sepsis that had 90% accuracy. Sepsis, high morbidity, high mortality, an incredible program. Published, proven results. One of the Epic, which makes the systems we use, Epic decided they weren't going to buy that program. They made their own sepsis program. It was 7% accurate. So, not everything that's AI means it's accurate or not. So you need to be surely certain that it works and works on your population.
I think the other thing to highlight is the importance of really collaboration between data science and AI experts and physicians, because AI can do a lot of things that aren't useful, right? So you need the physicians and the clinicians to really say, here are the big problems in any disease, right? As Elliot mentioned, we want to be able to diagnose pancreatic cancer when it's small, not when it's advanced, right? So you need to kind of be able to aim the AI brain power and the computational brain power at the right questions. And then also, as has been mentioned, making sure that the data sets that are being used to train them are really robust and applicable and not biased in any way. So I think collaboration is really key to making this work well.
Yeah, and that gets to, I think, one of the questions actually that came in the chat of one of the individuals pointing out there have been lots of very public examples of people, AI not doing the best job, particularly writing legal briefs and things like that. And that might actually be one of the areas where the rigor and the tradition and the focus on safety in medicine is helpful, where there are standards here to make sure not only do you use AI to develop the algorithm, but need to test it
Yeah.
and show that it's reproducible. And I think, as you point out, Dr. Wood, having that collaboration between the data scientists and the biologists, and I know it's something that both of you have really not only talk about but exemplify in your own work of bringing those worlds together. And looking at a couple of questions, so there have been some questions that came through about specific people at risk, either because of a known germline mutation or a family history, and what should they be due for screening. I will say first is people should go out and make sure that they talk to their physician, talk to a genetic counselor, because risk can be different depending upon the mutation that you have or depending upon how many family members. Um, and if it is appropriate, if it does, cross the threshold where surveillance makes sense, it would be the kind of programs that we talked about before. That would be, annual or every 6-month imaging, either with MRI or with endoscopic ultrasound going forward. And there's, more information about that online that we can share, but it really is probably best to start with, talking with your physician and meeting with a genetic counselor. There also were some questions about, and this came up earlier in the conversation, about these liquid biopsy or multi-cancer detection tests that got a lot of press, have generated a lot of interest from the pharmaceutical world and are being developed. So I don't know if either of you want to comment sort of where the CancerSeek and the GRAIL tests, or now it's CancerGuard, sit in their development and where the promise is with those kinds of approaches.
Yeah, I mean, I think that there's still a lot of testing being done on those approaches. I think one challenge that comes up is that if you have a positive blood test and then no abnormality on imaging, right? So you have somebody who's at higher risk, but then they don't have something that you would consider taking out surgically or even anything to biopsy. And I think that has become a new clinical scenario, again, where improved imaging and AI and imaging is potentially really useful. I think for pancreas in particular, the circulating tumor DNA levels tend not to be that high, which is maybe not expected, at least was not intuitive to me. But I think that those tests have a role, but at the same, or will likely have a role. The trials aren't totally done, but I think that that's not going to be the kind of fix for everything or the solution to everything. I think we're going to need, imaging as well as blood tests as well as other approaches.
Right. Yeah. As Laura said, if you look at both the results from Grail and Exact Science, that some of the results were published recently, there's a lot more work coming out in the first half of next year. If you had 100 patients get a test, 3% will be 3 out of 100, 3% will be positive, 97% will be negative. If you looked at those three patients, two of the three or 3 out of 4 will end up being positive, but one will not. And as Laura mentioned, that's the challenge. So you end up, if you're positive, you get a CT scan, you get a PET scan. But what if the CT and the PET are both negative? Then your worry is, oh, maybe the tumor is too small. What do I do now? Or maybe it's just a false positive. So I think it's for patients, it's stressful. If you pick up an early tumor, it's wonderful because a lot of the tumors picked up are stage 1 or stage 2. So that's terrific. But that other patient where it's positive and we found nothing, is a challenge. But I think that's always going to be the risk. But as long as you know going in, there's all sorts of things now. It's like I'm sure many of you have read in the newspaper because there's a lot of famous people who endorse it, whole body MR.
Mhm.
That's coast to coast. There's a few different companies. We're going to scan you from the top of your head to the bottom of your foot, and we're going to find everything wrong with you, or give you a stamp of health and get like a 25-page report. It's a long report. But the fact is it's not very accurate because if you want to look at the pancreas with MR, you need to do a certain protocol. If you want to look at the brain, you need to do a certain protocol. If you want to look at the spine, if you want to look at the kidneys, you want to look at the liver, you would need 20 different studies. You're just doing one fast study and saying $2,500, good luck to you. So, this idea about screening and doing everything, I think, it's important and has great potential, but it also can cause great harm. People
Yeah.
speak to me about these whole body MRs, and I tell them, I said, okay, you can do what you want, but here is the final result. You're going to come back to me and said they found X, Y, and Z in my study. What does that mean? And then we're going to have to do another test to show it probably means nothing. So
And I
it's
think
just challenge.
Yeah, I was going to say, I think all of these screening and surveillance approaches are a balance between, the epidemiological terms are sensitivity and specificity, meaning how likely are you to get a false negative, so to have somebody that has the disease but gets a negative test, and how likely you are to have a false positive. And I think, there is no perfect test, and you're always kind of trading off between false negatives and false positives. So I think applying the right type of test to the right clinical scenario is really important.
And so, not surprisingly, we've had a lot to talk about, and this has been a wonderful time. We're coming up towards the hour, so I want to make sure we pause a little bit and have a chance to recap here. So I will say, if my goals were originally that we want people to understand that, why this is such a hard challenge, but why right now is a time where the opportunities are growing. I think we've hit on that. We've talked a lot about, we don't have the right tools to assess risk for the whole population right now. Our instruments for detecting, especially the earliest and precancers, are blunt or, still in development. But because of insights that we're getting into what's different about the biology of the pancreas and what's really driving early tumors because of advances in not the approach to imaging, but the approach to analyzing imaging. The tools in our toolbox are just really growing, and it's giving us so much more opportunity and giving us a lot of hope that things will change in the future, and we will be able to do things more importantly, more impactful for our patients. But maybe we'll leave it as a way to close. I'll give you each an opportunity to talk about, kind of what started, what are you working on now, but not now, maybe move to like, what's giving you hope now, but also what's on your wish list? What do you wish that, we could do differently or do more to really have an impact? And maybe I think we started with you, Dr. Wood, the first time, so we'll start with Dr. Fishman now to kind of give us your closing thoughts on how we can continue to do more and work faster.
Right. I think the biggest thing for us, and I know Lustgarten and speaking with Andrew or Linda, is okay, it's great. You're doing research, stuff looks good. When does it impact our patients? When we speak to Microsoft, Juan Ferez, who's head of AI for Microsoft, he goes, okay, papers are good, doing things are good. When is it going to be available for everybody? So I think the thing that we're most focused on is the bench to bedside. We need to be able to move everything we're doing so that patients can benefit now. The future is now. We're not rushing, we're not going to be sloppy, but we all understand we need this now. And that's really what our focus is.
Yeah,
Well
and
said.
I think from my perspective, what I'm really excited about is there's a lot of development of technologies to study human tissue, and so we can understand early cancer and even advanced cancer as it occurs in human patients, kind of at scale, either analyzing cold tumors or analyzing large pieces of tissue and really getting a comprehensive understanding of how pancreatic cancer initiates, how it progresses, and then that can really lead us to data-driven approaches for interception and early detection.
Well, Dr. Wood, Dr. Fishman, thank you so much. This has been illuminating for me. I'm excited. I know we have a lot more work to do. I'm sure you guys both have a lot of work to do and work that you're excited to get back to the lab. But we appreciate you taking the time to speak with us and especially to help our community really understand the importance of this work and why it's so exciting right now.
Thanks, Andy and Dr. Fishman and Laura. As we mentioned, this is the conversation and the discussion that is most asked for by our community, and your insights and your passion for your work is so clear, and you are clearly driving what's coming next for patients, and that's so important. So we really appreciate you taking your time to be with our community today. And our next LustGarten Live is called Genomic and Genetic Testing, which actually bears somewhat on what we were discussing today. So, genomic and genetic testing for pancreatic cancer patients and why it matters. This takes place on December 10th. I'll be joined by Erin Billups, national health reporter at Spectrum News, Doctors Jeff Boyd and Dan King from Northwell Health Cancer Institute to discuss how the latest advances in genetic and genomic testing are transforming how we detect, treat, and manage pancreatic cancer, and how these innovations are making personalized care a reality for patients. So check your inboxes, and we'll see you next month. Thanks, everybody.